Hello, I am Dr. Sourabh Kulkarni. I am an orthopedic surgeon and a robotic joint replacement surgeon. So the intention of this video is to clarify exactly how planning of surgery done in a MISSO robotic planning software. So here we should understand that MISSO is a fully automated robotic system. So this being a fully automated system, we have to precisely give a 3D CT scan of patient's knee to the robot. And those points, which are usually important for deciding patient's implant, also those points which are very important to have a haptic boundary of patient's knee, they should be provided with very much precision by the surgeon. So usually a CT scan is required, which should be from hip, knee to the ankle. There are few specifications required for this CT scan. The CT scan machine should be 16 slice CT. It should be a good quality machine. The increment of images should be 1 millimeters of increment. Usually 600 to 900 images are required to be given to the software depending upon the patient's length. And once this CT scan is incorporated into the software, artificial intelligence helps you in auto segmentation. What is segmentation? Usually a segment that the femur and the tibia, they have to be segmented separately.
So now we will be seeing exactly how in a robotic software the planning of a patient's surgery is done. So this is a 51-year-old female with grade 4 osteoarthritis. So her CT scan has been uploaded to this robotic planning software, and if you can see here, the AI based segmentation has been done. So what is the meaning of this segmentation is, in segmentation, the femur and the tibia, they have been segmented into four parts. One is a proximal femur, then the distal femur, proximal tibia, and distal tibia. And collectively, these four segments, they form a complete 3D model of the patient's bone. If we can see here, we can see all how exactly this CT has been made into a 3D CT scan, 3D model. This 3D model looks okay and good to me. There are no any gaps. There are no any lacunae here. So now after this, a femoral axis points. They are usually given by AI in the software. If we see, these are the points which are required for femur to form a femoral axis to which at 90° we will be putting the implant. So these are the points. This is now head center. Usually the head center is given very precisely by the AI. I haven't changed my hip center in any of my planning till this point. Then comes the condylar center. In condylar center, again here if you can see in sagittal plane, it looks fine. In coronal plane, it looks okay to me, or maybe I can take it a little bit medial. Then comes is the medial epicondyle. So this medial epicondyle we have to see in axial view. See, this is where our MCL is attached. Also in coronal view, we can see a good point for medial epicondyle. Lateral epicondyle, the most prominent part here where the lateral collateral ligament is attached. Then comes is the medial posterior condyle. So this is the medial posterior condyle. We have to zoom it. I usually try to zoom maximally possible, and I usually take the posterior most point, because whenever in a conventional knee replacement, I will be putting a zig. That zig will be touching the posterior most point of my medial posterior condyle. So from this posterior condyle, the distance, how much is to be cut, will be decided by the software, and those values will be given to me by the software. Then comes the lateral posterior condyle. Again, sagittal view will be enlarged. Now you can see here a little bit, it is in air. So what I'll do is I will try to get it on the bone. So usually here also we have to see this is the inner cortex and this is the outer cortex. Many times software can take the inner cortex, but surgeon has to choose the outer cortex of it. Then comes the medial distal condyle. The coronal image will be enlarged and we have to see the center of medial distal condyle. This point looks good. Then comes the lateral condyle. Again in the coronal section, it looks okay. I have to enlarge it. Okay, it is at the outer cortex of lateral distal condyle. That is good. So after this lateral distal condylar point is chosen, we will move on to tibial axis. So why is this processing at this point is because we have chosen few different points than what the AI has chosen previously. AI have already given you implant sizes and placement according to the previous points. When you choose your own points, again the processing will be done and the implants will be chosen exactly according to the points you have given in a fresh way. So for the tibial axis, we have to choose a proximal center. So this is the proximal center which is given by AI. So I think it is good. Then I will go to coronal view. In a coronal view, I will check whether it is at the center or not. Yes, it is at the center. Then comes the ankle center. In a coronal view, the ankle center is exactly at the center of talus, which is good. Then seeing on a sagittal view, ankle center looks fine to me. Then comes the tibial tuberosity. Here the tibial tuberosity is here where it is attached, where the patella tendon is attached. On axial view also, yes, it is the most prominent point. Then I will go to PCL fossa center. Here if you can see in a 3D view, PCL is exactly, this is the PCL attachment on the femur. So PCL fossa center is also good. The medial condylar center. In a coronal view, I will again try to maximize. It is at the center, yes, a little bit more medial. This would be the center of medial condyle. Then comes the lateral condyle in an enlarged view. This point also looks fine to me. Now, after taking these tibial axis points, we have to go to the femur registration. So these femur registration points, they don't have any impact on planning implants, but these femoral registration and tibial registration points, they have to be chosen for initial mapping of the femur and initial mapping of the tibia. These points, they have to be chosen by surgeon before entering into the operation theater, because these points, if he knows perfectly, he can reproduce them perfectly in the operation theater, and the initial mapping RMSE, root mean square error, will be minimum. Now comes the medial epicondyle, but we are used to seeing the femur from foot end when we are doing the surgery like this. So here what we have to do is go in a foot view and check the point. exactly taking the point of the medial epicondyle is little bit tricky because there is an attachment of MCL, there are soft tissues there. So I usually try to take the point which is more on a bone, which I will not be missing on the operation theater. Then the lateral epicondyle. So again, I usually go in a foot view. We'll see in that way. And now I choose my lateral point. Then the distal notch. Distal notch is usually my point where is my entry into a conventional knee replacement surgery. Now what we have to understand here is these points you cannot choose or change on axial, coronal or sagittal views. You have to choose all these points only on a 3D model. Then comes the anterior point which is taken exactly at the notch. Then the anteromedial, then anterolateral point is chosen. Posterior point should be taken exactly in the notch like this. Then comes is the posterior medial point. So this is the posterior medial point, and comes is the posterolateral point. Then we will go for the tibia points, tibial registration points. Usually we are seeing femur from foot view, but we are seeing tibia from the anterior view. So I will choose all my points from anterior view. So in anterior view, the proximal point is here, my lateral point. See, this is our tibial tuberosity. If you can see here, this is our tibial tuberosity. The patella tendon will be attached here. So going too much lateral is not possible behind the patella tendon. So usually what I try to do is I try to take in a AP view, if you see, I try to take a little bit lateral from the center. Then comes the medial point, which is usually here. Then the tuberosity, most prominent point. Then the anterior point. What I do in anterior point is I usually try to see the tibial axis, which is defined by the tibial spine, and in line with that tibial spine I take the anterior point here, so I will not miss that anterior point. Then comes the proximal medial point, and then comes is the proximal lateral point. So after giving femoral registration and tibial registration points, you have to exactly replicate these points in the operation theater so that your initial RMSE of femoral mapping and tibial mapping will be less. RMSE is a root mean square error. Now we will go to the implants. So these are the implant sizes given by AI considering the dimensions that you have entered into the CT scan. So we will start with the coronal axis. In coronal axis,
Size D.
you can see there is a significant lateral overhang. I will scroll all the images. The mediolateral overhang or mediolateral placement of the implant has to be seen at the level of pegs. Okay, so here there is a little bit of medial space. So I will take this implant on a medial side. Even if I take it on a medial side, there is a little bit of lateral overhang here. So I will consider that into my mind and will try to change it to the size C whenever possible. Now I will go to a sagittal view. In sagittal view, what I will see is the anterior notching. See, now I'm going medial. On medial side, there is significant space for me. As I come on a lateral side, there is some space on a lateral side also. See, so what I will try to do in this case is I will try to keep this implant posterior. I will try to push this implant posterior and we'll see if there is any femoral notching or not. Now I have gone a 0.5 millimeters posteriorly, no notching. Again 0.5, I have gone posteriorly. Now with this 0.5, I am doing a femoral notching here. So I will try to re revert it. Okay. So now, because my medial lateral overhang, which I'm not happy with, I will try to choose a size C. If we can enlarge this image at the level of pegs, I can see there is some space for me to medialize this implant. Okay, so now my implant is sitting exactly at the center and there is no medial and lateral overhang. Now what matters? Now see, here we have to see a posterolateral cut. This posterolateral cut has to be in line with the recommended posterior cuts of the femur. So as per the recommendation, it should be 8.4, 8.5. So what I can do here is there was some space to go posterior. So I have taken it posteriorly, another posterior shift. Now there is a femoral notching. So I will not do a femoral notching. But now at this point, my posterolateral cuts are 8.8 and posteromedial cut is 8.8. So these two cuts are 8.8. But when I go in this axial view, I can see my patella is not sitting exactly at the trochlea. It looks a little bit of more internally rotated. So what I do here is I go in a internal rotation and external rotation thing. I will try to do a little bit of more external rotation like this, and this is good for me. My patella is sitting at the center of my implant's trochlear groove. So now if you can see, because I have externally rotated this implant, the posterolateral cut has become 8.5. With 8.5, I am happy. If I have to reduce it further, I cannot take this implant posteriorly, but there is another option which I can do is to do the flexion of the implant. So if I do the flexion of implant, see, with the 0.5 degrees of flexion, there is 8.5 to 8.3 transition of this posterolateral cut, which is acceptable for me. So I will take this implant planning as good, but there is a little bit of femoral notching it is showing. So to avoid this femoral notching, I will anteriorize the implant, which again is making my posterolateral cut to 8.8. So the option that I have is to make this implant more flexed. So if I flex it to 1 degree, 8.6 millimeter posterolateral cut is there. With 1.5 degrees, it has come to 8.4. So here now my implant is 1.5 degree flexed with a perfect posterolateral cut. Now I will be choosing size C and going further with the tibial implant planning. Now this is the planning given by the AI in the software for the tibial implant, which is size 2 and slope of 3 degrees with proximal lateral cut of 9 millimeters. Okay, so but usually you should understand the proximal lateral cut we take in a conventional knee replacement is 9 millimeters. In conventional knee replacement, most of the times the cartilage of 2 millimeters is already present on lateral condyle. So the effective bony cut that we take in a conventional knee replacement on a tibial side, on a lateral side, is 7 millimeters of femoral bone and 2 millimeters of cartilage. So here I will initially change this proximal lateral cut to 7 millimeters, considering the 2 millimeters of cartilage. 8.5, 8, 7.5 and 7. and then accordingly I will try to put my tibial implant. Because our tibia is a conical shape, your sizes will change at the 9 millimeters of proximal lateral cut, and it will change as per the 7 millimeters of proximal lateral cut. So now this is my planning for tibial implant. Size, it is showing a tibial overhang. It is on an anterior side. If you see, the implant is little bit more anterior. I will take it posteriorly like this. Now it is centered at the AP diameter. My tibial keel is not notching on a posterior or anterior cortex here, which is good. Then I will see a coronal view. In a coronal view, I have a little bit space on a lateral side. I will try to lateralize it, because in cutting path, I don't want to damage my MCL. So now this is a little bit lateralization. I think it looks good for me. Then I will go to the final plan. But before going to the final plan, one more thing in a femoral implant. Now see here also, the distal medial cut for the femur is 9.8 and the distal lateral is 4.1. So as this is a varus knee, the lateral side on this knee will have a cartilage. So my distal lateral cut here will be 4.1 plus 2 millimeters, that is 6.1 millimeters, and my distal medial cut is 9.8 millimeters. In ideal conventional knee replacements, the implant has been made with the 9 millimeters of distal cut. So I will try to take this implant a little bit on a inferior side like this. I will change my distal medial cut to near 9 millimeters. So this is my planning for the femur, this is my planning for the tibia, and this is my final plan. So in this final plan, if you can see, my distal medial cut is 8.8, my distal lateral cut is 3.1, my posterior lateral cut is 8.4, my flexion is 1.5 degree to the femur, femoral implant, external rotation of 1 degree, and in tibia, my proximal lateral cut is 7 millimeters, proximal medial is 0.9 millimeters, and slope I have kept to 3 degrees. Initially, the hip knee ankle axis was 173, that is 7 degrees of varus it was showing, and now it has come to 180 degrees, that is exactly neutral.